Educational intervention to improve the knowledge of anesthesia providers in the use of dexamethasone and ketamine to prevent postoperative sore throat, a quality improvement project. Learning goals. By the end of this project, anesthesia providers will be able to generate a care plan to minimize the incidence and severity of postoperative sore throat. You will be able to determine the efficacy of dexamethasone and ketamine in the prevention of postoperative sore throat. You will be able to differentiate between the potential benefits and risks of the use of dexamethasone and ketamine in the prevention of postoperative sore throat. You will be able to apply the evidence presented in your clinical practice safely. You will be able to describe the importance of addressing postoperative sore throat preoperatively, and you will be able to outline the main risk factors, adverse consequences, and preventative strategies of postoperative sore throat. Problem identification. Tracheal intubation is performed to secure the airway and provide mechanical ventilation during general anesthesia. This procedure causes irritation and inflammation of the airways, leading to postoperative sore throat. Postoperative sore throat is often dismissed or overlooked by anesthesia providers because it is a temporary complication of tracheal intubation. And numerous research studies have proposed interventions to minimize the incidence of postoperative sore throat, but there are no standards of care or protocols to prevent this complication. Background of the problem. Different anesthetic techniques can influence the development of postoperative sore throat. Large endotracheal tubes, excessive cough pressure, prolonged intubation, multiple attempts, and blood in the airways are associated with an increased incidence of postoperative sore throat. Smoking, female gender, and young age have also been linked to an increased incidence of postoperative sore throat. Tracheal intubation is the leading cause of postoperative sore throat. Its incidence is significantly lower when supraglottic devices are used for general anesthesia. Scope of the problem. Millions of surgeries occur yearly in the United States, with approximately one-third requiring tracheal intubation. Postoperative sore throat can occur in 30 to 70% of the patients requiring tracheal intubation. It increases the length of stay in the postoperative care unit and therefore the cost of care. The incidence of postoperative sore throat is lower in children, but it's difficult to assess for sore throat in this population, and the provider's intubation skills play a major role in preventing it. Consequences of the problem. Postoperative sore throat can prolong eating or drinking, cause electrolyte imbalances and dehydration, and thus prolong surgical recovery. It is a major cause of patient dissatisfaction. It can be a symptom of more concerning complications such as vocal cord or laryngeal injury. It can range from mild irritation to an incapacitating discomfort that prevents patient from swallowing or speaking. Dexamethasone is a glucocorticoid steroid that reduces inflammation by inhibiting prostaglandin synthesis, serotonin concentration, and the release of inflammatory mediators. The anti-inflammatory effect of dexamethasone reduces the edema caused by airway trauma during intubation and consequently the incidence and severity of sore throat. Ketamine provides analgesia by inhibiting the NMDA receptors, which are activated by glutamate, an excitatory neurotransmitter in the brain. NMDA receptor antagonism blocks the transmission of pain to the central nervous system. Ketamine's analgesic effects can provide pain relief caused by airway instrumentation and in turn reduce the incidence of postoperative sore throat. When administered alone, a single dose of intravenous dexamethasone before the induction of anesthesia decreases the incidence and severity of postoperative sore throat. Doses of 8 and 10 milligrams are effective in preventing postoperative sore throat after 6 hours postoperatively, but a significant improvement is not seen within the first 6 hours after extubation. A dose equal or greater than 0.2 milligrams per kilogram is needed to provide coverage for 24 hours postoperatively. In a study using a dose of zero point 0.2 milligrams per kilogram, the incidence and severity of sore throat were more uniform during the first 24 hours after surgery, and only minor pain was reported by patients. Nebulized dexamethasone provides an effective alternative to the intravenous route. This can be particularly useful in patients without intravenous access before induction, such as pediatrics. A study demonstrated that the outcomes with nebulized dexamethasone are similar to those achieved with intravenous administration. Ketamine gargles administered before the induction of anesthesia decreases the incidence and severity of postoperative sore throat. A single dose of 20 to 40 milligrams mixed with saline can be used for gargles. Unlike dexamethasone, ketamine gargles provide better outcomes in the immediate postoperative period. Two studies found a higher incidence of sore throat after 6 hours postoperatively. A problem with gargles is that patients need to be able to protect their airway to avoid aspiration. Nebulized ketamine can be used in these cases, yielding equally effective outcomes. In fact, nebulized ketamine was found in two studies to provide sore throat relief uniformly for the first 24 hours after surgery. Ketamine can be combined with dexamethasone to achieve better outcomes, especially in the early postoperative period when higher doses of dexamethasone may be needed to prevent sore throat. This can be particularly helpful in patients who cannot tolerate high doses of steroids, such as diabetics. In a clinical trial, 40 milligrams of ketamine gargles combined with zero point 0.2 milligrams per kilogram intravenous dexamethasone were administered to patients. The incidence and severity of postoperative sore throat was lower than in the trials involving a single drug at all measured intervals in the first 24 hours after surgery. The synergistic effect of these drugs offer better pain control for the first 24 hours after surgery than each drug administered alone. Adverse effects of dexamethasone and ketamine when used for the prevention of postoperative sore throat. A single dose of dexamethasone is not associated with side effects observed in the long-term administration of corticosteroids. A mild increase in blood glucose has been reported, but only in the immediate postoperative period. None of the clinical trials reported any complications from the administration of dexamethasone. Low doses of ketamine used for the prevention of postoperative sore throat do not significantly contribute to sedation, hallucinations, delirium, and hemodynamic instability. No difference in the level of sedation was observed in the experimental group in the ketamine trials compared to the control group. The effect of ketamine usually lasts about 20 minutes, which may account for a slight increase in heart rate and systolic blood pressure, but once the effect wears off, these parameters are similar to patients who do not receive ketamine. Take home points. A single dose of intravenous dexamethasone administered before the induction of anesthesia decreases the incidence and severity of postoperative sore throat. Ketamine gargles are also effective in reducing the incidence and severity of postoperative sore throat. In contrast to low doses of dexamethasone, ketamine gargles offer better outcomes immediately after surgery, and its effects diminish over time. Ketamine can be combined with dexamethasone to achieve better outcomes. The synergistic effect of these drugs offer better pain control during the first 24 hours after surgery than each drug administered alone. The administration of a single dose of these medications is not associated with any significant adverse effects. Thank you for listening to this presentation.